The cardiovascular system assessment and equipment. The cardiovascular equipment that needs checking is the A line and the A line site. The A line stands for the arterial line, which will normally be in the right or left radius. The arterial line is marked with a red line all the way down the side for safety. This alerts people that it is not a regular giving set. The A line is always monitored and monitor alarms switched on. This is part of the safety checks every day in ICU. Check your A line for any air bubbles which must be removed so they do not enter the patient. An ICU nurse will guide you on this. Nothing is to be injected into the A line, and there must be special ports which prevent this. The site limb that the A line sits in, usually the arms, should be visible at all times. This site should be cleaned and dressed with an intact see-through dressing. Central venous lines. The CVP line and infusions attached. The CVP line may have a blue line running all the way down or may be clear. There are some infusions that have to go centrally as they destroy the smaller veins. These will be attached here, and you should take some time to familiarise yourself with which lines are attached and if they are in date. All lines attached to your patient must be labelled with what's in them and dated at the patient end. You may need to stop an infusion in a hurry and disconnect, or connect an infusion in a hurry, and you will want to identify a port for this prior to needing it. Each of the A line and the CVP line will have a pressure bag and saline bag attached. Each will have 500 ml of normal saline 0.9%. The bags sit in a pressure bag which needs to be increased to a pressure of 300. This is indicated by a green section on the pressure bag gauge. You will need to check the bag of saline has sufficient fluid in them and that they are up to the pressure before you zero the set. An ICU nurse will show you how to zero, but I will talk you through it now. The transducer level. Both the A line and the CVP line are continuously monitored, and in order to know that your readings are accurate, you will need to zero the transducers. This is part of your checks at the beginning of each shift, and if you disconnect the patient for any reason. Transducers should sit in line roughly with the right atrium. Both lines should be switched off to the patient and open to air at the correct height, with the pressure bag blown up, and then you press zero all on the monitor. You will then switch them both back to the patient, put the caps back on, and they should be reading correctly. This will be more clear when the ICU nurse shows it to you. Checking and assessing your patient is next. Check your patient's heart rate corresponds on the ECG and the A-line trace, and feel their radial pulse. Check they are the same. Check your ECG tabs have good contact and are correctly placed. Some patients may have 5 lead monitoring, others will have 3. Any significant change in heart rate should be confirmed with a manual pulse, blood pressure and output checked, and a 12 lead ECG taken. Do ask for help early. Make sure that the blood pressure or map is adequate and note whether they are requiring any fluid or drugs to maintain it. Check the patient's temperature. Anything above 39 degrees needs to be acted upon, and ask for help. The theatre's ICU can get chilly. A cold patient is as much of a worry as a hot one. Bear huggers are available to warm your patient up. Check the patient's 4 limbs and check for capillary refill time and peripheral pulses. Note skin pallor, i.e. is it pink or dusky, and warmth. Whether sweating is present, skin is dry, and check any wounds for new bleeding. Check all line insertion sites for any sign of infection or migration. The urine output. Urine output is a late sign of an inadequate blood pressure and should be kept at 0.5 ml per kilo an hour. You will be guided by this by the intensivist. It is part of your hourly observations along with your input, which we measure, and everything is documented. All sedated ventilating patients will likely have a urinary catheter. If your patient has a low blood pressure, poor urine output, they may be commenced on a group of drugs called inotropes or vasopressors. Some common inotropes and vasopressors are noradrenaline, adrenaline and metronidazole, but there are others. Which inotrope is used will depend on your local policies and the patient's presentation and type of shock. They should be given through a central line. They require an A line to be sited and monitored. They are continuous infusions and should not be allowed to run out as they are very short-acting drug. When you check the lines and infusions, check how much is left in your infusion and ensure you are ready with the next one at least an hour before it is due to run out. An ICU nurse will help you with this. This is a matter of safety as your patient's blood pressure could become low and may result in cardiac arrest or deterioration if the infusion is stopped or delayed. Inotropes are measured in micrograms per kilogram a minute, but titrated to maintain an adequate map. This is usually guided by the intensivist and normally will be 60 to 65 millimeters of mercury. Please be aware that should your infusion rate be increasing, it is important you inform an ICU nurse or a doctor. IV fluid boluses may also be given, but less often than on the wards. Electrolytes are closely monitored in ICU. The main ones are potassium greater than 4 but no more than 5.5 millimoles, magnesium greater than 1.0 millimoles and phosphate greater than 0.7 millimoles. These are the main electrolytes that affect the heart, conduction, contraction and rhythm, and they are all tightly controlled and monitored daily.